Hello all, welcome back to my channel. In this module, we're discussing the next part of infections, which is quite confusing again, that is parasitology. But once you understand the characters of different parasites, the lab diagnosis, the treatment, and the clinical features becomes a bit easier. So let's get into the video. So parasites, in a medical perspective, it is mainly characterized and categorized into two, which are protozoans and metazoans. Metazoans are helminths or worms, and protozoans are again classified into amoeba or sarcodina, the sporozoans group, the mastigophora group or the flagellates, and the ciliata group, which are the ciliates. Metazoans or helminths are again flatworms or platyhelminth and nemathelminth or roundworm. Platyhelminth again can be flukes like our liver fluke and others, and cystoda, which are the tapeworm. Okay, so parasites, amoeba, sporozoans, flagellates, and ciliates. Metazoans or helminths are roundworms and flatworms. Flatworms are again divided into tapeworms and flukes. Now this is another way of looking at the parasites, the ones which are having a direct life cycle or they have only one host, which are protozoans like Giardia lamplea, Trichomonas vaginalis, and Balantidium coli. And helminths, which are having a direct life cycle, are Ascaris lumbricoids, Trichuris trichura, and Ankylostoma duodenale. And there are parasites which are having an indirect life cycle, meaning they have a host where there is sexual reproduction happening, that is a definite host, and an intermediate host. In some cases, man is the intermediate host, in some cases, man is the definite host. And the examples are Plasmodium, like a Plasmodium vivax or whale, the mainly malarial parasite. Then Toxoplasma gondii, which is again another important parasite, where the definite host is a cat. And it's causing toxoplasmosis, mainly in immunosuppressed individuals. Then we have Cystodynia solium, which is causing cysticercosis. There, the intermediate host is pig. Trematode like Fasciola hepatica, which is a liver fluke, where intermediate host is snail and definite host is man. And another nematode, Wucherera bancrofti, where intermediate host is mosquito, like Culex, especially for Wucherera bancrofti, it's Culex. Okay, so they can have either a direct life cycle or an indirect life cycle. Now coming to protozoans in detail. Protozoans, as I told, they are classified into four: amoebas, flagellates, ciliates, and sporozoans. Amoebas is our amoeba species. Flagellates are trypanosoma, trichomonas. Okay, we have also Giardia. Then ciliates are Balantidium coli. Then sporozoans are mainly important species are Plasmodium or malarial parasite and Babesia. Okay, coming to the amoebans or entamoeba, they can cause intestinal amoebiasis and extraintestinal manifestations. Intestinal amoebiasis is where they cause a discrete flask-shaped ulcers or bottleneck ulcers, and they present mainly with dysentery, and the stool is having an offensive smell. The diagnosis can be made by stool microscopy, where we see eosinophils and charcoal-laden crystals. The extraintestinal manifestations can be liver abscesses, and this liver abscess is important. Amoebic liver abscess is important, and pulmonary manifestations where they can present with chocolate brown sputum. Amoebic liver abscess, the usual site, common site of infection is right lobe of liver due to the streaming effect in the portal venous flow. So majority of the blood is streamed into the right lobe. So the commonest site of infection is right lobe of liver. Okay, because it is getting into the intestine and then getting penetrating the intestinal wall and then going into the portal circulation. So then they are streamed and deposited in the right lobe. present mainly with right hypochondral pain, which is due to the stretching of liver capsule, and they can from the liver they can spread to other parts where they can form an amoebic lung abscess, which again cause an anchovy-source pus. And the patient can present with diarrhea or dysentery. Lab parameters can show a raised ALP. Again, the amoebic liver abscess can rupture and cause maybe peritonitis and other complications. Lab parameters, we can have a raised ALP. Chest X-ray may show a raised right hemidiaphragm. So this is a usual clue that I have seen the questions, that there is a history of dysentery with the X-ray showing raised right hemidiaphragm. Think of amoebic liver abscess. The diagnosis of choice is amoebic serology, which is usually conclusive, and the treatment is metronidazole. Diloxanate furoate is to eliminate the intestinal luminal cyst so that there is no further spread. Okay, so metronidazole is the drug of choice. Diloxanate furoate is to eliminate the intestinal luminal cyst. Okay, then coming to Giardia. Giardia is the only protozoan parasite which is found in the small intestine. Okay, and they have a characteristic motility called the falling leaf motility. They have two forms, trophozoites and cyst forms, and the usual presentation is with diarrhea, that is mucus diarrhea, steatorrhea. There can be lactose intolerance, epigastric pain, and flatulence. So usually in the question, when there is a chronic diarrhea and steatorrhea and some features of lactose intolerance, always think of giardiasis. And the diagnosis is by string test. String test is done, and the treatment is metronidazole. Again, for even for amoebic liver abscess, it's metronidazole. So once you know the class of the parasite, you know the treatment. Okay, coming to trichomonas, again another flagellate, which causes trichomonas vaginalis. Okay, and they have a rapid, jerky, and twitching motility. So since they have a flagella, they have a high and characteristic motility. Giardia have a leaf, falling leaf motility, and Trichomonas has a rapid, jerky, and twitching motility. And the characteristic features are offensive yellow and frothy discharge from the vagina with a strawberry vaginal mucosa. Okay, so this is characteristic of Trichomonas. Usually in the history, there is a female coming with offensive discharge from the vagina, and there is erythematous changes in the vaginal mucosa. That is pointing towards Trichomonas. Again, treatment is metronidazole. Coming to trypanosoma, we have Trypanosoma brucei, Trypanosoma cruzi, and Trypanosoma lewisi. Trypanosoma brucei is the one causing African sleeping sickness. Trypanosoma cruzi is causing Chagas disease. So African sleeping sickness, the vector for the disease is fly, and they present mainly with chancre at the site of bite. There is lymph node enlargement, hepatosplenomegaly, and increased daytime sleepiness. Okay. The CSF picture may show a raised ICP with pleocytosis and raised protein. And treatment can be metronidazole or pentamidine. Okay, so there is African trypanosomiasis or sleeping sickness caused by Trypanosoma brucei. Uh, there are two species, West African and East African, Trypanosoma gambians and Rhodesians. That is two different genuses. And the vector is fly, present with chancre, lymphadenopathy, and somnolence or increased daytime sleepiness. Then there is American trypanosomiasis, which is Chagas disease caused by Trypanosoma cruzi. They have a chagoma, which is a subcutaneous nodule at the site of that insect bite, and there is periorbital edema. And chronic Chagas disease usually manifests with cardiovascular and GI manifestations. Cardiovascular manifestations can be myocarditis, which can progress later on into heart failure. There can be a right bundle branch block and arrhythmias, or they also may complicate to DVT and pulmonary embolism. The GI manifestations can be megaesophagus and megacolon. The treatment can be benznidazole or nifurtimox. Okay, so there is sleeping sickness caused by Trypanosoma brucei and Chagas disease caused by Trypanosoma cruzi, which is having mainly cardiovascular manifestations. Now, another flagellate is leishmania, which causes Kala Azar or Indian visceral leishmaniasis. Leishmania also have many genuses. The vector for the disease is female sandfly. They have two forms, promastigot and amastigot. Amastigot are found inside the macrophages and they form LD bodies or Leishmania donovan bodies, LD bodies inside the macrophages. Okay. And the clinical features include fever, night sweat, and there is generalized lymphadenopathy. There is massive splenomegaly, hepatomegaly, and weight loss. And there can be grey skin. That is why it is called Kala Azar or black fever, due to the greyish discoloration of the skin. There are mainly three forms: mucocutaneous, cutaneous, and visceral leishmaniasis. This visceral leishmaniasis is caused by Leishmania duodenowani, which is called the Kala Azar or black fever. Mucocutaneous form is caused by Leishmania brasiliensis, and cutaneous form, which goes like a very discrete ulcer like thing at the site of infection, and that is caused by Leishmania mexicana. And the treatment of choice is sodium stibogluconate or meglumine antimonate. They are antimonials, sodium stibogluconate and meglumine antimonate. The side effect of this treatment is cardiac arrhythmias and acute pancreatitis. So that is leishmaniasis. Now coming to our important protozoan parasite, which is malaria, which is a sporozoan. Four genuses for Plasmodium falciparum, Plasmodium vivax, Plasmodium ovale, and Plasmodium malariae. Plasmodium falciparum is the most severe form, which is also causing cerebral malaria. But Plasmodium vivax and ovale can have a relapsing type of infection because they have hypnozoites in the liver. That is an additional stage which is not happening in case of falciparum. So in case of vivax and ovale, we can have a relapse of infection. And the vector is female Anopheles mosquito. And falciparum, they do not grow in RBCs that contain HbF, C, or even sickle cell trait HbS. So they are protected against the lethal complications of malaria. So a patient who's having sickle cell is protected against the lethal complications or cerebral malaria. Okay, because the falciparum do not grow in such RBCs. And for Vivax to attach to the RBC, they need a receptor which is related to the Duffy blood group antigen. This has been asked in the question: which antigen is related to the malarial parasite attachment? That is Duffy group. So if Duffy negative, like in West African population, they are naturally protected against Plasmodium vivax. Okay, so we have mainly two. You can characterize and categorize like two: Plasmodium vivax and ovale, and Plasmodium falciparum. Falciparum is causing the severe manifestations, and vivax and ovale mainly they present with anemia, thrombocytopenia. They can be jaundice and hepatosplenomegaly. Splenic rupture is common in vivax and not in ovale. Falciparum, there is usually malarial paroxysms of fever, and the patient is usually very ill with a classical typhoid facies. There can be neurological complications, again present with hemolytic anemia, hepatopathy, where there is raised bilirubin but the enzymes are not usually that raised. There is cerebral malaria, which is the severe and complicated form of malaria. There can be renal failure and ARDS as a complication, and black water fever due to again hemolysis, and acidosis and DIC can be another complication. Now, there are some certain things you need to remember in case of malaria. A patient once admitted with malaria, there has been a question which goes like this: a patient admitted with malaria, they are started with quinine treatment. A patient then has a rapid fall in GCS and they may have seizures. So the usual cause is hypoglycemia because quinine can cause hypoglycemia. Hypoglycemia is not simply because of the starting of quinine treatment. Malaria itself can predispose the patient to hypoglycemia due to excess glucose utilization and also reduced gluconeogenesis. But another common cause is starting of quinine as a treatment in patient with malaria. Quinine has a serious side effect of hypoglycemia. You have to give dextrose to that patient. Okay. Then black water fever, falciparum malaria can itself complicate with hemolytic anemia and black water fever. But otherwise, again in Vivax and Ovel, when you're giving primaquine, G6 in especially in G6PD deficiency individuals, primaquine can predispose the patient to hemolysis. Again, they can present with black water fever or hematuria. Okay, for malarial treatment, mainly we are using either chloroquine or artemisinin combination therapy. For falciparum malaria and cerebral malaria and severe malaria, we're using artemisinin combination therapy, which is given IV. And otherwise, in Vivax and Ovail, we are using chloroquine. But again, Vivax can have chloroquine resistance, especially in Indian population. So we are using again artemisinin in that case. And for Vivax and Ovail, we are giving additional primaquine for eradication of that hypnozoid stage. Prophylaxis of malaria is given to patients who are traveling to malaria endemic regions. And we have a short term prophylaxis which is given like a daily prophylaxis. And the drug of choice is doxycycline. That is started 2 days before travel to and continue 2 weeks after travel. And mefloquine is given weekly. They are started 2 weeks prior to the travel and continued even after travel. Okay, that was malaria. Coming to babesia, which is another sporozoan, they are tick-borne, and the diagnosis is mainly done clinically and present similar to malaria. They have hemolytic anemia, hemoglobinuria, hypergammaglobulinemia, and people who are without spleen, splenectomized individuals, they have an overwhelming infection. Okay, so that is babesia. Now coming to toxoplasma. Toxoplasma is important because it causes toxoplasmosis in immunocompromised individuals. In immunocompetent individuals, they resemble a picture like infectious mononucleosis or glandular fever. There is lymphadenopathy, fever, and things like that, and they are a self-limiting infection in immunocompetent host. But in immunocompromised host, they can cause toxoplasmosis. The CT picture is very classical. Multiple ring enhancing lesions. So the diagnosis is toxoplasmosis, and the treatment of choice is sulfadiazine plus pyrimethamine. Sulfadiazine plus pyrimethamine. So we usually don't give as prophylaxis to patients with HIV, but this cotrimoxazole prophylaxis is started in patients for PCP, for pneumocystic carinii or pneumocystic Erovici pneumonia, and that will cover for this as well. So as such, we don't recommend prophylaxis, but that is started. Then there is vertical transmission, which is causing congenital toxoplasmosis. Remember, in torch infection, T stands for toxoplasma. So that can present with convulsions, hydrocephalus, chorioretinitis, retinopathy and cataract, and cerebral calcifications. Okay, coming to cryptosporidium. Cryptosporidium is a parasite which is known for causing diarrhea in compromised individuals. So they present with watery diarrhea, abdominal cramps, and fever, and may complicate to form sclerosing cholangitis and pancreatitis. Stool examination with modified Ziehl-Neelsen stain can show the characteristic red cysts. So that is a classical diagnostic feature, stool showing red cyst with modified Ziehl-Neelsen stain. And treatment of choice, for especially this is happening in a patient who is HIV positive. So the treatment is starting ART in that treatment. In that patient will itself resolve this condition. Or specifically, you can give nitazoxanide in these patients. Okay, so that was protozoans. We have seen amoeba, flagellates, chelates, and sporozoans, which is the important ones are especially malarial parasite. There has been many questions regarding that. Coming to nematodes, which are the roundworms. So nematodes again can be intestinal nematodes and tissue nematodes. We'll see the intestinal nematodes first. Intestinal nematodes are Enterobius vermicularis, Escalus lumbricoides, Strongyloids stercoralis, hookworms like Ankylostomma duodenale, Necata americanus, and Trichuris trichura and Trichinella spiralis. This some of these are transmitted via soil, so that is why they're called soil transmitted helminth. Mainly Ascaris lumbricoides, Strongyloids stercoralis, hookworms like Ankylostomma duodenale, Necata americanus, and Trichuris trichura. They are soil transmitted helminth. Coming to enterobius, they are called seed worm, and the treatment is albendazole. Albendazole is usually given to the whole family together because they spread within the family. Fecal-oral route is a transmission, especially seen in children, and they present with severe perineal itching, especially during the night because the worm comes to the perineal region during night. They have high activity during night. Then Ascaris lumbricoides, another soil transmitted helminth. It can form two kinds of manifestations. One is due to the called the Loeffler syndrome. That is due to the larval migration. Okay, that is Loeffler syndrome. There is eosinophilia, migratory pulmonary infiltrates, and eosinophilia in the peripheral eosinophilia in the blood. So that is what is called Loeffler syndrome. And the worm itself can clog in the intestine and cause intestinal obstruction. And the treatment is albendazole. You can give pyrantel pamoate or piperazine to, especially in the intestinal manifestation like intestinal obstruction. To eradicate that, you can give piperazine. Okay, this is an intestinal obstruction causing whirlpool effect. That is what it is called in an erect abdominal X-ray. We can see intestinal obstruction with multiple air fluid levels, and it's called whirlpool effect. Now coming to strongyloid species, Strongyloids stercoralis, which is again a soil transmitted helminth. It is causing creeping eruption in the site where the larva is migrating. It's causing creeping eruption in the skin, under the skin, and due to the speed, it's called. It is a very fast motility. It's called larva currents. Mainly, the itching happens in the sole and in buttocks region, and they're prone for auto-infection, especially in an immunocompromised individual. They can cause auto-infection. Auto-infection means this is not going back into the soil. It is spreading from the person. It is multiplying, and again multiplying into a very large number of organisms. And it causes disseminated infection in immunocompromised, where there is history of diarrhea, there are granulomatous changes. It can complicate to form perforation peritonitis, pneumonitis, and meningoencephalitis. Treatment is ivermectin. For strongyloids, the treatment is ivermectin. For hookworm is again a soil transmitted, and it causes anemia, iron deficiency anemia, and hypoalbuminemia. Again, as we told, there can be groundage at the site of the worm spread, and they can migrate into the lungs, causing the Loeffler's like picture. There is cough with blood tinged sputum, and stool occult blood is also positive. Okay, and there is eosinophilia. Coming to trichuris, which is called the whipworm, it can cause trichuris dysentery syndrome, which is a triad of rectal prolapse, especially in children in the endemic areas, clubbing and chronic diarrhea. Rectal prolapse, chronic diarrhea, and clubbing. That is the trichuris dysentery syndrome. It is called whipworm. So that was our uh, intestinal nematodes. Coming to tissue nematodes, which are filarial and non-filarial. Filarial worms are again classified according to their habitat into lymphatic filaria and cutaneous filaria. Lymphatic filarial worms are Wuchereria bancrofti and Brugia malai, which is causing our elephantiasis. And cutaneous filaria are Dracunculus medinensis, Loa Loa, Onchocerca volvulus. Among that, Loa Loa has been asked in exam. So filariasis, there are two species, Wuchereria bancrofti and Brugia malai. And the vector is mainly mosquito. For Wuchereria, it is Culex mosquito. For Brugia malai, it's a species of mosquito called Mancinoids. Okay, and the treatment is by DEC. Um, and also there is one test which is used. It's called DEC provocation test. Because um, uh, these worms have a predilection to come into the blood during night time, we are giving DEC in this patient, and within 30 minutes there is a spike in that worm in the blood. So you can collect blood after 30 minutes of administration of DEC. That's called DEC provocation test. Again, treatment is by DEC. Another filarial worm is Loa Loa. Okay, that is cutaneous filarial worm. It causes subcutaneous and subconjunctival uh, tissue. In the subcutaneous, there can be swelling, and can also be the worm can be seen in the eye. So that is causing subcutaneous swellings, which are called the Calabar swellings. Again, treatment is DEC. So for filarial worms, it is DEC. Onchocerca, it is called the blinding worm, or it causes river blindness. And the vector is female black fly. Female black fly, and treatment is ivermectin. Filarial infections of Wuchereria bancrofti, Brugia malai, Onchocerca, and Loa Loa. Wuchereria bancrofti and Brugia malai are causing elephantiasis, and they are mainly located in the lymphatic vessels. And they have a nocturnal periodicity. That's why we are doing a DEC provocation test to help, detect the worms in the blood, peripheral blood. And the vector is mosquito, mainly for Wuchereria, it's Culex. Lab diagnosis is by blood film. Onchocerca volvulus is causing onchocerciasis or river blindness, and they are found in the subcutaneous tissue. And microfilaria can be seen in skin and eyes. There is no periodicity like in Wuchereria or Brugia. And the lab diagnosis is by skin snip test. Okay, Loa Loa is causing loiasis, and it's moving in the subcutaneous tissue. There is a diurnal periodicity, and the vector is chrysops species or deerfly. So for Onchocerca and Loa Loa, it is fly. For Onchocerca, it's black fly, and Loa Loa, it's deerfly or chrysops. And the diagnosis by blood film. So those were our nematode species. We had seen intestinal nematode and tissue nematode. We had seen filarial nematode, non-filarial nematodes. We had seen soil transmitted helminths as well. And there is something called Loeffler's syndrome. There is eosinophilia and migratory pulmonary infiltrates. Coming to tapeworm. The tapeworms are, there are different species of tapeworm, which is Typhlobothrium latum, and that is called a fish tapeworm, and they cause pernicious anemia. Treatment is praziquantel or nitrosamide. There is Hypnolepis nana, it's called the dwarf tapeworm. It is rarely symptomatic, it's usually asymptomatic. Treatment is praziquantel. Tinea saginata and Tinea soleum are important. Tinea saginata is beef tapeworm, Tinea soleum is pork tapeworm, and that Tinea soleum has a larval stage which is called the cystic. For neurocystic sarcosis, it's albendazole or surgery. For others, it's praziquantel. Echinococcus granulosus is another tapeworm which is causing the hydatid cyst disease, and treatment is albendazole or surgical removal. And there is another Echinococcus genus which is multilocularis, which is causing alveolar cyst disease, which cause multilocular cyst. In hydatid, it's a solitary tissue cyst. In alveolar cyst disease by Echinococcus multilocularis, it's a multilocular cyst. Again, treatment is albendazole or surgical removal. So we'll come to the important tapeworms. Echinococcus species, they cause hydatid disease, and the host is dog. Intermediate host is sheep. And there was one test, intradermal test, which is Cassoni's skin test. Skin test called Cassoni's skin test, which is no longer used. But remember, there is a skin test for Echinococcus, which is called Cassoni's skin test. And the treatment is surgical removal, or for hydatid we talk about the hydatid cyst has hydatic cyst fluid which is highly antigenic, so you cannot just aspirate the hydatid cyst. When you're aspirating, there is a technique called pair, that is puncture. You puncture the cyst, you aspirate the cyst, you inject again city, and then you re-aspirate. Okay, that is the technique called pair: puncture, aspirate, injection, and re-aspiration. So this is our hydatid cyst in the liver. It has several layers, that is ectocyst, endocyst, and uh, pericyst. So endocyst, which is inside, that is called the germinal layer. Okay, and they have brood capsule, uh, which is containing the daughter cyst, and there is a hydatid sand, and there is hydatid fluid. Hydatid sand is this species, this daughter cyst. They are settling down in the dependent region. That's called the hydatid sand, and there is hydatid fluid which is highly antigenic. And there is a laminated layer outside the germinal layer. Okay, and there is an adventitious layer further outside. Let's see your hydatid cyst. So that was Echinococcus species. Coming to Taenia, we have Taenia saginatum, which is a beef tapeworm, and Taenia soleum, which is pork tapeworm. The larval stage is called cystic. Neurocysticercosis by the egg stage. Larval stage is causing cysticercosis. Cysticercosis can be seen in the subcutaneous tissue. It can be seen in the muscle. Neurocysticercosis in brain, and can also be seen in the ocular tissue. That is where these larval stages are spreading. And in the X-ray or in the brain imaging, we can see calcified cyst. Okay, this is an X-ray showing calcified cyst. And the treatment is albendazole and praziquantel. Okay, so that was Taenia and Echinococcus, which are two important tapeworm. Coming to trematode or fluke, according to their habitat, they are divided into blood fluke, which is schistosoma species, liver fluke or fasciola species of Fasciola hepatica, intestinal fluke, which is Fasciolopsis buski, and lung fluke, which is Paragonimus westermanni. So we'll discuss the important ones, which is schistosoma. Schistosoma is a blood fluke, which is schistosoma hematobium. We have schistosoma mansoni and schistosoma intercalatum and schistosoma japonica. Schistosoma hematobium is causing urinary schistosomiasis. It can predispose the person into squamous cell bladder cancer. It's not transitional cell, it's squamous cell. Okay, Schistosoma hematobium can predispose into squamous cell bladder cancer and causes swimmer's itch. Presence with fever, cough, diarrhea, arthralgia, and urticaria. There can be bladder calcification and diagnosis by urine or stool microscopic examination. Treatment is by praziquantel. Schistosoma mansoni and Schistosoma intercalatum cause intestinal schistosomiasis, and Schistosoma japonicum cause schistosoma encephalitis. Another species, that is Clonorchis sinensis, which is the Chinese liver fluke, transmitted by ingestion of the larva in undercooked fish, and they can form biliary complications like pigmented gallstone, cholecystitis, and cholangitis, and also predisposed to cholangiocarcinoma. So these flukes are predisposing into malignancies. The Schistosoma hematobium predisposed to squamous cell bladder cancer, and Clonorchis sinensis predisposed to cholangiocarcinoma. Okay, that's all. So we have seen parasites, which are classified into protozoans and are worms or helminth. Protozoans are further classified into amoebas, flagellates, ciliates, and are sporozoans, of which important one is a malarial parasite. And we have seen the worms, helminth. We have seen nematode, which are roundworms. We have seen flatworms and flukes. So that's all. Stay tuned for more updates on MRCP. Thank you so much for listening.